morning, Warriors. Welcome to the fourth and final for this year's series on cervical reconstruction or cervical rehabilitation. So I'm excited that today we have a live platform with Zoom. So hopefully I'll be able to get to see some of your faces afterwards too when we get into the question and answer period. So we're going to build on what we've been talking about. And let me start by sharing my screen here. And Dr. Yuri, can you see my screen here?
I can, yep.
Perfect. Okay, so I just want to begin by quickly reviewing everything we've done this year, because I've tried to, as much as possible, build on the information from one webinar to the next. So again, 4-part series we started back in April or May, and we just kind of started to add and tie this all together. So the very first thing that we looked at was really why. Why are we doing this, right? We looked at the research to substantiate or to support what we're doing in our offices as corrective care, subluxation-based chiropractors. So we touched on the research from chiropractic biophysics, which showed us the normal modeling or the normal position of the spine. Then we talked about, okay, great. So we know we have a normal position. We know how to measure it. And we saw that when we could use Denner rolls, we can use these home orthotics in addition to our adjustments in the office to help bring our patients back to that normal or ideal spinal position. We taught you guys how to measure some of these subluxations or some of these deviations on x-rays. We talked about measuring anterior head translation and loss of curve were really the two primary indicators that most of the research today is looking at. And I've been actually just going through some more research recently, not even CBP stuff, but I've been looking into spinal surgery, looking at orthopedic surgeons, and you'd be shocked as to how much information there is out there and how much even these surgeons are starting to use these measurements, and they understand this stuff, and they're actually referencing Dr. Don and Dr. D's work in terms of spinal modeling and how they should be fusing spines. So when they're actually putting a curve back in the neck, they're looking at this and saying, okay, we should be putting a lordosis back in the cervical spine as we fuse these patients, because this is so important to get the proper curve and to reduce the anterior head translation on these patients if they have, significant disc herniations. And God forbid we're letting these patients get to surgery. We can do this stuff conservatively in our offices while at the same time improving their overall health. We talked about the pizza angle. So if the patient is a candidate for using a cervical orthotic at home, how do we estimate how much curve correction is possible? And again, Dr. Kwan gave us that awesome formula of going pizza angle minus 40 degrees, gives us a rough estimate of how much curve is possible for a given patient. I taught you guys how to measure the slope of C7 and T1 relative to vertical. And this was a very important measurement because it allows us to determine if we should be looking at, a primary cervical problem, or if we should turn our attention and focus on, thoracic hyperkyphosis and look at this as a thoracic primary subluxation. And in terms of also using a thoracic orthotic for our patients. And then building on that, I showed you guys some cases where we would use a thoracic orthotic where the indicators were not cervical Denner roll, but more of a thoracic Denner roll, and how we could get amazing cervical curve correction by putting a thoracic orthotic into the patient's hyperkyphotic thoracic spine. And so last webinar, the question came up twice. Okay, doc, that's great, but what do we do in cases of hypokyphosis? So not when there's too much rounding in the thoracic spine, but what do we do when there's a loss of curve in the thoracic spine? And so, I touched on it a little bit, but I thought since it came up twice, it's a good question. Docs want to learn about it. So I built that into today's presentation, talking about mild loss of thoracic curve. And then we're going to show you guys a couple examples of extreme loss of thoracic curve and how we would approach that. Okay. So we've been talking about correction with traction. And I've been hitting you guys over and over with using Denner rolls in terms of traction. But today I want to touch on exercises, because if we really want to get the best overall results, not only in terms of, curve correction, I know that's what we're doing. Those are things that we're measuring. But for the overall patient outcomes in terms of their functionality, their health, we need to add exercise to the patient's regime. People are sedentary, right? More than ever with COVID, they're sitting at their computers, bad postures. We need people to exercise and move. And so we have these great simple devices called Pro-Lordotic neck exercisers, which do a wonderful job of helping to put a curve back into a patient's neck. And they are a great addition to doing these cervical dental rolls as well. So we're going to talk about the exercises, but then it was actually a perfect tie-in because when we add these exercises, we can really help to improve thoracic kyphosis in those cases where we've lost some of that thoracic curve. So when I was training with Dr. Deed in Idaho at the or at the Doctors Institute, the Ideal Spine Health Center, this is what he talked about and what he taught over and over again. It was the EAT protocol: exercise, adjustments, and traction. And ideally, yes, we would do all three of them in that order. In other words, patients would do their exercise, they would get their spinal tissues warmed up, we would adjust them, and then they would do their traction, okay? But the reality is it's not always practical, depending on your clinic and your setup, to be able to do it in this order. If we get all three of those components, though, we definitely get our best results, right? So the adjustment, there's the art in the chiropractic, and you're adjusting your patients however you choose to adjust them. That's great. The traction, we've been talking about this over and over. It's using dental roll products to traction their spine at home. But we also want to exercise the patients, okay? So I'm going to start by showing you guys this video. Let me go here. I think I'm going to have to screen share. We're going to go for a new share, and I'm going to bring you guys to a video here. I'm going to go here, and hopefully everybody can see this video. And what I'm going to show you guys here is a video, and this is on my YouTube page. So if ever you want to review this video on my YouTube page, I always put these exercise videos or exercise or dental roll coaching videos on how to use these products, okay? So the Pro-Lordotic neck exerciser, you can have the patient do this in office, or you can have them do this at home. And we'll talk about the difference between the two in a minute. Okay. But what they do is they grab the exerciser, they bring it forward. Okay. There's different positions depending on where we want to put this in the neck. Okay. So right now with the arms parallel to horizon, this would be targeting the mid neck in a case of loss of cervical lordosis. Arms down would be targeting the lower cervical spine, and arms up above horizon is the upper cervical spine. So depending where you want to target or where you see the most loss of curve, you can have the patient adjust their arms accordingly, okay? Now what they're going to do is they're going to put their arms out again. So they lock out that band, they bring their arms forward. And what we're going to do is have the patient perform some extension of the skull. So they're going to look up and then retraction. They kind of squeeze their head back and hold that. So we're really stretching out, everything on the front aspect of the spine and really strengthening the muscles on the posterior aspect, which get very weak with loss of curve in anterior head translation. With any exercise that I teach my patients, it's always the same protocols, okay? I have them hold a postural exercise for 10 seconds. They rest just a couple seconds in between, and they repeat that 20 times. 20 times is basically the minimum dose that I give my patients, okay? The reality is if we looked at the CPP research, they recommend that patients do 100 reps per day, right? Now that becomes a lot. Not all patients are going to do 100 reps. So I ask my patients to perform 20 repetitions. That's kind of that minimum dose to get us the results that we need, okay? Now, prior to COVID, our office, we had all of our cervical dental roll patients do this exercise in the office, okay? For a couple of reasons. One, because if I send them home with this Pro-Lordotic neck exerciser, for those non-compliant patients, the patients that are not doing their dental rolls are likely not going to do the Pro-Lordotic at home either. So if I had them do this in the office, I could ensure or guarantee that they were getting at least 5 minutes of exercise 3 times a week while they were in the office, right? And the other reason is I could watch them do it to ensure that they were doing the exercise properly, okay? And I'm going to show you guys a couple of pre-post cases here where patients were not compliant with their dental rolls at all, but were using the Pro-Lordotic in the office 3 times a week while they were getting adjusted, and we still managed to get some really good curve corrective results. Now, because COVID is higher, we're code red, we can't have as many people in the office, we have to have a quicker turnover. We've stopped allowing people to do this in office, and now we're simply sending all of our patients home with Pro-Lordotic neck exercisers. So every single patient that gets a dental roll also gets the Pro-Lordotic neck exerciser to do at home, okay? But that's only started, I would say, as of about 2 to 3 weeks ago. Prior to that, we always had our patients do it in office so we could ensure at least some accountability for these exercises. Okay, so here's an example. Now, I'm not going to go through these measurements. We've hit these over and over. If you haven't watched the previous webinars, you can. But here's an example of one of those cases where the Pro-Lordotic is mandatory. This is one of those cases where, she's borderline too much anterior head translation. Her slopes of C7 and T1 are close to being, too far to vertical. She could use a cervical dental roll. She could use some sort of thoracic orthotic. She kind of falls right in between, but she's 15 years old, extremely flexible, and her head is way far forward. And this is one of those cases where if I did traction alone and I didn't add exercise, the results might not be so great, because in these young flexible patients, they can lay down on a dental roll, they stretch, and as they pop up, their tissues are so elastic, they just recoil back to this terrible position, and they're spending 10 hours a day in this forward flex position on their phones, on their computers, right? So in these cases, it is wonderful to add a neck exerciser like this to help strengthen the tissues. You're going to get way better results. Okay. And that was the mistake I made with this young lady at first. I didn't give her a Pro-Lordotic, right? I went by my indications. I thought, okay, maybe she could just do this posture regainer, this thoracic orthotic at home. And after a couple months, I noticed that her posture wasn't changing. Her head was still way forward. And so I took a stress x-ray. I made her take the Pro-Lordotic. I put it at the bases of her neck, and you can actually see it right here. You can see the Pro-Lordotic, you can see the rubber band, and she's pulling into that low neck, pulling down. And all I made her do was just lift her chin a little bit and retract her head. And you see her curve goes from 9 millimeters to 29 millimeters. Beautiful. She's 43 millimeters forward. With the Pro-Lordotic, she goes down to 13 mils. So if she does this repetitively and consistently, this is the result that I can expect from this patient. Okay. So again, whenever I'm in doubt, I stress x-ray everything. Now, here is a case, and I'm just going to move this around because I don't know what you guys can see on your screen. Hopefully you could see the pre-post there. So this is a case of a young lady that did exactly what I was describing earlier. She was extremely inconsistent with her dental roll use at home, and she admitted it to me, which I appreciated. And so we saw her over the course of a year. So over the course of her year correction, I kept asking, are you doing your exercises at home, your dental roll? Nope, nope, nope. She was rarely ever doing it. But she was extremely diligent about doing her Pro-Lordotic after she was adjusted every time in the office. And so this is the type of correction that we got with just pretty much doing exercises. She was 8 degrees before, and she ended up with a 25-degree neck curve. Okay. That's a beautiful change for just adding some exercises for 5 minutes in our office after being adjusted. Okay. Now, her pizza angle, I have it at 62 here. I have it at 69. I would say this one's blurry on the right. This isn't the best x-ray. If I had to estimate between the two, we could split the difference, right? Let's fall right down dead smack in the middle. We'd be at about 65, 66 degrees down the middle here, okay? If we use Dr. Kwan's method of saying pizza minus 40, her normal neck curve, or an ideal neck curve for this young lady, would be about 25 degrees. And you can look now, boom, 25 degrees. This patient is pretty much maxed out in terms of her correction now, or at this point, I'm extremely happy. This patient's neck meets her anatomy. This is a wonderful correction. She should have a very, very healthy neck curve moving forward, and she should be able to maintain this for a very long time now that we've got her spine back to its ideal normal position, okay? Let's move this guy again one more time. Okay, now here's another one. This is a patient who told me right off the bat she was not going to be able to be consistent because she was a traveling nurse. She traveled to the northern communities up in Manitoba. And so I did send her home with both the dental roll and the Pro-Lordotic. And she was decent with the dental roll, but she admitted to doing the Pro-Lordotic more. And if we look here, she started out with 3 degrees of curve, and after a year of care, it took her a year to get 32 visits in office, just to show you how inconsistent she was. But she was diligent with her home care at least. And so she goes from 3 degrees to 22 degrees. So that's a big, big change, about a 19-degree curve change in her neck. But what's most exciting in her case is she's got this really bad kyphosis at 4.5. And though it's not perfect, it's still kyphotic. It is a drastic change from here to here. Okay. If she was doing the dental roll alone in this case, I don't think she would have got the same results without having exercise and really strengthen those tissues back here to help solidify a case like this where there is a strong kyphosis. These kyphotic segmental cases are very tough to change. And oftentimes docs send me x-rays on these saying, hey, I'm having a hard time. How do I fix this? How do I change this? They've been doing their dental roll, very little change so far. My answer is almost always add Pro-Lordotic neck exercisers, because it can make a wonderful difference by adding some strength and some motion in here to keep those segments healthy. Okay. Now I want to show you her thoracic spine. So now this lady, she didn't do any thoracic traction. So here's where we get into those cases of thoracic hypo, so loss of the thoracic curve. So I'm going to go through this very slowly. I'll repeat it. And if someone has questions, we can hit it at the end of the webinar. As I mentioned in those previous cervical webinars, when the cervical spine loses its normal curvature, or we start to have loss of the cervical curve, almost always we have a simultaneous loss or reduction in the thoracic spine. Okay. So when we get loss of the cervical curve, simultaneously, almost always, we get a reduction in the thoracic curve. So as we put a curve back into the neck using the cervical dental roll, using a Pro-Lordotic neck exerciser, we can increase the thoracic kyphosis. Now, this is in cases where it's a mild loss. So we have a slight reduction of a thoracic kyphosis. Okay, when we start getting 50% loss or 50% curve reduction or more, this is not going to work. Okay, it's going to be much more challenging. For those of you who don't know the measurement in the thoracic spine, a normal thoracic kyphosis is 44 degrees, right? So if I'm, in the 30s or in the 20s, can I expect the thoracic spine to increase closer to normal by using a cervical dental roll and by doing Pro-Lordotic neck exercises? The answer is yes. Okay. If you remember, I described that the peak and the very unique design of the cervical dental roll was designed to put curve into the neck, but also to increase thoracic kyphosis, a slight increase in thoracic kyphosis. So here's an example of this lady, right? This was 11 months to complete her 32 visits, but she did the dental roll and the Pro-Lordotic at home, and her thoracic curve was slightly reduced, not crazy, but it was 37.9. And after doing the Pro-Lordotic and the dental roll, she goes up to 41.5. So, we have 3.5 degrees of correction. Again, not crazy, but we didn't do anything to the thoracic spine. This was just retraining those upper thoracic ligaments, retraining those muscles with dental roll and Pro-Lordotic, and you're going to get some thoracic curve improvements. Okay. Now let's go. I'll show you one that's a little bit better change, or even a little bit flatter. Okay. So this lady now had 27 degrees. So a 38% loss. So a larger loss. And she was another one. This one here, Flato told me, same thing, not good with her home dental roll at all. This was almost entirely Pro-Lordotic change, but she did her Pro-Lordotic consistently after all of her adjustments. And after 32 visits, we have 10 degrees of cervical curve correction and 5 degrees of thoracic correction. So post, she went from 27 degrees to start, and she's now 32 degrees. Again, it's not like a wow change. We're not increasing it by 20 degrees by doing this, but it is incrementally better, right? Her neck is significantly better, and she is on her way to getting a healthier, better spine. Now, if we keep going, and she's actually due for re-x-ray soon here for one more time, 6 months later, we'll see where she's at and how much more she's managed to improve. But it's all that to be said, by the addition of these products, we can improve the thoracic kyphosis. Okay. Now, here we go. So now let's talk about cases where I got to move this for myself here, where it's probably more than a 50% thoracic reduction. Okay. So if we look at both of these cases, these are two different types of spines, but they have significant loss of a thoracic kyphosis. Okay. These cases, if I just put a cervical dental roll and I put a Pro-Lordotic under these patients' necks alone, I'm probably not going to make much of a dent in these. These are quite challenging to fix. Okay. I love the challenge on them, but I'm always, I hold my breath to see how much curve change was going to be, because these are generally ones where you have to target all three areas at the same time if you want to create change. So we have two different patterns here. We have the anterior and we have neutral. Both of them, though, you'll notice curve reduction. Okay, let's talk about the neutral one. What I mean by neutral is when we're looking at sagittal balance. Sagittal balance means, forwards or backwards. C1 relative to S1. Okay, depending on the literature, they'll use different landmarks. But, Cole's Notes versions, we're looking at C1 over T1, right? Or in our case with anterior head translation, we talked about C2 over C7. We're basically measuring the same thing. We're looking for balance here. We want to see C1 over T1 over T12 over S1, right? And if we look in this case, it's not perfect, but she's pretty darn close to being in balance the top of the spine over the bottom of the spine. So this is a true loss of curve in all three areas. Okay. This spine is more challenging to change than this spine. Why? Because when I see this one, so everybody can appreciate if I'm using my software, Posture A here, the green line is where this patient should be based off of their pelvis. I won't go through the same measurements, but you can see that the software put the line on the patient's spine for me. This patient is shifted significantly anterior, right? They have anterior sagittal balance. Now, when the spine shifts anteriorly relative to the pelvis like this, I'm going to say it again slowly. When the spine or the thorax shifts anterior relative to the pelvis, the normal pattern for the thoracic spine is to flatten. The thoracic spine flattens to try and compensate for this anterior shift. Okay. So I know in a case like this, if I can train the spine to go backwards, I can improve that thoracic kyphosis simply by getting the spine to come backwards. Okay. So one more time. When a spine shifts anteriorly, the normal compensation pattern is to have a reduction in the thoracic spine, and it can reduce by about 13 degrees. Okay. So by shifting it backwards and getting it into a normal position, I can get approximately a 13-degree correction or improvement in the thoracic kyphosis simply by shifting the spine back. Okay. So these two patients are going to have different home care and different in-office traction setups. Regardless of the pattern I see, just so we're clear on this, on these cases, I'm always going to recommend these patients do traction in office because of the amount of force I'm going to want to put on these spines to try and put those curves back in. Okay. So let's look at office traction. So this would be the anterior pattern. I would lay them face down in my office. And here is the neutral pattern. Okay. The anterior pattern, I lay them face down. Actually, I'm going to mention one more thing, and this is really important. One of the ways to know that the spine has shifted anterior in these flat thoracic cases is the TL junction becomes lordotic. Okay. It should be flat or kyphotic, right? The thoracic spine is kyphotic. But right here, between, we'll say T10, T11, and L1, L2, you have a lordosis. So the spine is reversed in this position. And that is like a telltale sign that I've shifted anteriorly. Okay. You look here, it is not. It is flat, right? This is not a shifting pattern. If I shift this person backwards, I am not going to be necessarily increasing their thoracic kyphosis, and I could potentially create more problems in their lumbar spine. So this is the telltale pattern here. I need to pull on that lower kyphotic area, on that lower lordotic area and drive it backwards. So I have these patients, whether in office or at home, lay on their tummy. Okay. So in office, I would build up some blocks at that TL junction. I put a strap and I pull like crazy, right? 100 plus pounds of force pulling back. And you can see that kyphotic change, right? Really pulling hard into that area. I strap the pelvis, I strap the neck to try and improve the neck curve. At home, I have these patients lay prone, so face down on a lumbar unit, right? This is not comfortable. It's challenging, but it can work. So they lay face down at home, and just like this, the peak of my lumbar unit would be right here at the base of the sternum on this patient, and I have them lift their chin, rest on their chin to try and improve the cervical lordosis. In those cases where they have a neutral balance, right, I would do a complex setup like this in office, but for home care, they can lay on their back. Okay, this is the patient that I would need both dental rolls to improve the curve. So in these flat back syndromes like this, that with their neutral balance, I give them a cervical and a lumbar dental roll. In other words, they lay here, this improves the cervical. I have that nice deficit between the two to improve my thoracic spine, and I lay them on the lumbar unit. So now I get lumbar curve, thoracic curve, and cervical curve. My patients who are keeners and want the best results possible, if they're not doing traction in office, I tell them to get a 20-pound bag of rice from Costco, and I have them take that 20-pound bag of rice. So they're laying here, and that 20-pound bag of rice goes right on their sternum, trying to create force to really improve or induce that thoracic kyphosis. Okay. But either way, these are tough cases, but these are some of the things that you can do, because I don't want to discourage docs and say there's nothing you can do. You can always do something, right? We've got to be creative and give them everything we can. And these are some of the things that I do with these tougher cases, but they are much, much, much rarer than something like a hyperkyphosis when you see these true flat back syndromes. This young man, this case here, I want to show you his pre-post. So this anterior case, right? We worked with him in office. He was extremely diligent. He never missed a visit for those first 3 months in his first corrective plan. This is what we did with him in office. This is what he did here at home on the dental roll. And I want to show you his post x-rays after 3 months. Okay. So after 3 months, right? So this is where he started. This is pre, and then this is post over here, right? Pre and then post. So pre, I want you to notice a couple of things. Look at the distance. I split these into 3 different sections so we can appreciate them differently. We close the gap. Remember, I talked about that anterior translation. So on his post x-ray, you can see that that gap is smaller, okay? If I look at how far and how lordotic it is in here, you can see that it has been reduced. If I come up here to the upper thoracic kyphosis, I notice that he's flat up top. Well, you can notice it's been improved, right? So all of these markers are showing improvement. Now, the question is, did his thoracic spine improve because we actually changed his thoracic spine? Or was this curvature improvement simply due to the fact that we were able to retrain his spine to shift backwards? I don't know. One of those, at the end of the day, maybe it doesn't matter because we did get those results and he's doing significantly better. Now, the cool thing is, same thing is we didn't do any cervical traction with him, but I want to show you his cervical improvements by fixing or helping his thoracic spine. So here is his neck after that first 3-month care plan, okay? He goes from 1.4 degrees kyphotic to 12 degrees lordotic, okay? So a nice change. Again, not wow, not stunning changes, but they are the changes, you know, and we're en route. This is explaining to him, you know, this is the kind of stuff that we're going to be doing for, you know, weeks, months, if not years to come to continue to improve this. And we pulled really hard on him to the point where he would almost pass out in traction. And that's how tough those can be to change, but still they can be changed. And these are things that patients can do at home. Okay, so I hope that helped. Again, showing you guys how to use those pro-lordotic neck exercisers to be able to address most cases, and then some tips here and some things that you can do to help cases where we have significant flat back syndrome or significant reduction of the thoracic kyphosis. So once again, I appreciate you guys being on here. So every time we do these, I give you guys a code that you can use to purchase dental rolls or dental roll products to discount those for you. So here's a coupon code, WQ420. That will be good for the next 2 weeks or until December 1st, 2020. This again is our website that has all of the products, the different tools that we use to help our patients get well. My contact info, again, if this is the first time you're watching one of these, I don't check this email as often. So if you want to get a hold of me ASAP, send me an email to this one with tough cases or any questions that you might have. And lastly, there is my YouTube channel. So if you want to go on YouTube, you absolutely can to find any and all of those videos that I put out there to try and help docs use these orthotic products and dental roll products for the spine. So that's what I have for you guys today. I think we have a good half an hour here. We can open it up for questions, and hopefully we have some questions from some docs.
Yeah, I'll start. It's Yuri. Just curious. I mean, my impression from, taking CBP and doing all those semi-annuals years ago was that the thoracic spine is really difficult to change.
Yes.
Is that because you have the ribs attachments, and I've always kind of assumed that, I mean, other than the kyphosis, that was easier, but you were talking
Yes.
the flat thoracic spine, that must be really challenging relative to a C-spine or an L-spine.
It is absolutely challenging, and you're right, Yuri, and that is probably the main reason is it's so much stiffer. You've got like this natural scaffolding built around the spine, and so it's a lot harder to change, right? And so, the thoracic hyperkyphosis is much easier to change because you can have the fulcrum right in the middle of the back. They lay on there, the weight of the head, the weight of the rib cage can help open it up. And it's much easier to stretch it open than it is to try and round it and push it back into position. Much, much easier. So yeah, some of those thoracic hyperkyphosis cases, we definitely get decent results in flattening them from the side. But those flat cases, they are challenging, but you don't see them as much, right? Those are few and far between. And sometimes there's some genetic components too. You start measuring, like we talked about the pizza angle. Maybe they have like a 40-degree pizza angle or a very low pizza angle in their neck. And so they're going to be genetically prone to having a flat cervical spine, a flat thoracic spine. The downfall for those patients is though there's the genetic component, we can only control so much of it. We can put as much curve as we can, and those patients are going to have weaker spines. They're going to be more likely to be injured. They're going to require more care from us. They need to be under care probably more consistently than the patient that has a good curve, because they're weaker, more likely to buckle, and more likely to have problems. So even though we can't always change the curve, doesn't mean the fact that we shouldn't be working with them. To the contrary, those are the patients that probably need the most amount of care from us.
So what would you recommend as far as, what kind of outcome are you suggesting the patient should expect? Are you going like, this is just really tough and we'll see how it goes? Or are you actually saying, giving a prognosis?
Are you talking about the flat ones, like the flat thoracic spines?
Well, let's talk about both, like the flat and the more commonly the kyphotic.
So in the hyperkyphotic spines, the way that I know if they're going to change is you lay them face down. So if I'm doing my exam, right, and I'm standing them up, I'm looking at their posture, and I'll explain to them, okay, I can see before even taking my x-ray. Oftentimes in hyperkyphotic cases, you can see it, right? You can see that kind of the hump back, if you will, the rounding in the shoulders. And then if I notice that it looks like they're kyphotic, when you lay them prone, right, you're going to go do your spinal exam. And I don't know if you guys do spinal exams prone. As soon as, we've gone through things with patients, we have them lay down in the exam room and we do our spinal exam. If they lay down and you can see a clear hump or a bump on their back, that is not a good sign. That is a sign that that spine is likely not going to change. If they lay down and that hump that you saw standing gets significantly better when they're laying down, that means they're quite flexible, and there's a really good chance that we're going to be able to flatten it. So part of it is that patient's flexibility, but you don't really know if their kyphotic spine is flexible until they lay down. So you see it when they're standing. Oftentimes I'll just have them round their shoulders and bend forward and see how prominent it is. Okay, yes, I can see there's that bump there. They lay face down on my table. The bump looks the same. It's not going to change much. If they lay down face down on my table and you can push and you can feel some good tissue flexibility and it flattens a bit, then I have good hopes in telling them that, yeah, I think we're going to be able to change this. But typically what I'll tell them is, I'll tell them I've had great results with this in the past. Oftentimes we can change it and sometimes we can't. I tell them you could be one of those outliers that may not change. So I don't want to get their hopes up and that we can't correct it. But I explain that we're going to be not only looking at their x-rays, but we measure functional change, right? So we do different things like heart rate variability, and, we're taking outcome measures on them. Like we make them do a quality of life questionnaire called the SF-36. And so sometimes I don't get those curve changes. It happens. But I'll tell the patient, like, hey, listen, you answered this quality of life questionnaire. Like your quality of life is 25, 50% better than it was 6 months ago. Yes, we haven't changed your thoracic spine, but your functionality is better. Your nervous system is functioning better, and so on and so forth. So I'll start hitting the functional benefits if I can't change the spine. So I don't promise them anything, Yuri. I tell them I've had results with this. I think we can change this. We're going to try this. At the end of the day, this is what I'm looking for, but I'm also looking for nervous system improvements, functional improvements, which we measure with heart rate variability and the SF-36 questionnaire.
Okay, good, thanks. And by the way, your video is off. I don't know if you want that on purpose or.
My video's off?
Yeah, like the screen is up, but you're not showing up.
Interesting. Now?
Just looking at myself.
Interesting.
I can see him.
Oh, can you? Okay.
Yeah.
I can see him too.
All right, just me.
Dr. Glenn Lang.
Hi, everyone. Hi, Pascal. Thank you. This has been awesome once again. I just got a question. I'm trying to wrap my mind around this whole process. So if I'm treating someone that has a hyperkyphosis and I've determined that it is forcing that cervical spine forward.
Yep.
So I put them on a thoracic retrainer.
Okay.
And their curve improves at 6-month review. Say I do an x-ray and it improves. At what point do I stop treating the thoracic kyphosis and move to a cervical dental roll?
Good question. The answer is probably never. Okay. For a couple of reasons. Patients who have thoracic hyperkyphosis. So part of this becomes a genetic thing. Okay. So people that are hyperkyphotic in the thoracic spine are typically genetically prone to having it. They have a deeper rib cage. If you go back and you look at those previous webinars, they have a deeper PTSIA angle, pizza angle, right? And that is an indication of how deep, we'll say, like, if I turn sideways, how thick my chest is. And those more barrel chested patients are going to be prone to thoracic hyperkyphosis. And so you flatten that thoracic hyperkyphosis and you get it into, close to normal, or what we think is going to be the max change for that patient. They don't move to a cervical den roll. They would always be a thoracic den roll patient. It's just you would reduce the frequency with which you use it. So I have my patients do their orthotics at home every single day until I tell them otherwise. And generally that's going to be for almost the first year. I'm trying to get them to do it, to build the habit daily until I re-x-ray and I think I've got max change for that patient, or it looks close to normal. Then I have them do it once to twice a week. I tell them that's what I feel is good for maintenance to stabilize it. But they would never go to a cervical dental roll, because then what's going to happen is you're going to put them on a cervical dental roll. They're going to stop getting that stretch in the thoracic spine, and likely the ligament memory, their postural habits are going to start rounding them back into a kyphosis, and you're going to lose ground. So think of it like braces in a retainer. You're putting the braces on, you're stretching, you improve, and then you have them maintain, right? So it's correction. And from day one, when I do my reports, I tell people, like, we're going for correction. Once we have you corrected, we're going to determine what you need for maintenance. In other words, it's going to be really frequently at first to try and correct this, but you're going to need some maintenance to hold this in position, because your spine is going to want to revert back to its previous damaged position, or where you've built up those areas of stress.
And you're saying that about 70% of your cases are cervical dental roll?
Yep.
I'm fairly new to this, but I'm seeing a lot of hyperkyphosis. I must be doing something wrong. Mine are majority of that. Like, so you're saying when you put them in treat the kyphosis is over 44 degrees, correct?
Yes. Yes. Now, some of that, Glenn, we can get into some details. Remember, I just mentioned a couple of x-rays ago. I'll go back to it. I mentioned on this guy, let me erase my ink. So remember, I explained to you that when the thoracic spine shifts forward, it flattens, Glenn? Well, likewise, when the thoracic spine shifts backwards, so people that have like a poor slouchy posture, they will increase in thoracic kyphosis up to approximately 13 degrees. Now, those are different. Those are like postural kyphosis and not a true kyphosis. I didn't get into those details. It's like a pretty lengthy conversation, but you might be seeing higher incidence also of postural kyphosis, where, if you just had them stand up straight and shift their chest forward slightly and you re-x-rayed them, their kyphosis would probably be perfectly normal. Does that make sense? So you take away like slouch posture. If you just say, hey, stand up straight for me, drive your chest forward 1 inch, and you retake that x-ray, if their thoracic spine went from 55 degrees to 44 degrees, it's not a true kyphosis. It's just that they're slouching and you're seeing an increased rounding in the rib cage. That could be factor number one. Factor number two is where you're practicing, Glenn. You might have a higher incidence, right? Because again, some of these factors are genetic. Where do you practice, Glenn?
In Ontario, 2 hours north of Toronto. But a number of these people are patients that have been patients of mine for 25 years, but I'm new to this process. So I'm just now x-raying. And so they probably had some benefits from our adjustments in the cervical spine.
Yep.
And just not addressing that thoracic component.
Yeah. And then the other thing to think of is, how are you taking your thoracic x-rays? Are you having them hold? Can you see the elbows here? Are you having them hold their arms up like that?
Resting their arms on a thing like this. That needs to be changed. So we get our x-rays done at the hospital, so it does create some challenges.
Okay, so then there could be some positioning distortion too, right? They lift their arms up, and by lifting their arms up, and if they're reaching forward, they might be kind of rounding and having some projection distortion. Now, it is possible, Glenn, that you are just seeing a higher proportion of people with thoracic kyphosis too. So there are a number of things there, and I think it would be maybe unique to the situation you're in. The fact that you can't control who's taking the x-rays could be the age of your population. There could be some postural components. So there could be a number of things going on. But if we look at our stats and we go back in our database and see who's gotten what dental rolls, I would say 70% get cervical. And then, 10% I do lumbars, and maybe 10-20% are thoracic. Or we would say it would alternate between thoracic and lumbar.
Okay. Awesome. Thank you.
You're welcome, sir.
Okay, great. Thanks, Dr. Glenn. Anyone else like to or have any questions for Dr. Pascal?
So we're getting crickets here.
Yeah, it's quiet.
Well, Warriors, anybody got a question? We'll finish it up.
I have another one.
For sure.
I'll keep talking. I just don't want to hog the show. So like another thing that I've been wrapping my mind around is using the AHT measurement. And you're saying ideally it should be 0, but there's a 15-degree allowance, right? Or sorry, 15 millimeter allowance on that.
Great question. Great question. Go on, keep going if you're not done.
So how often do you do the retraction exercises along with that to correct that? And how far do you go? Like, are you happy with 15 millimeters, or do you go for 0?
Great question, Glenn. So here's how I'm going to answer this. I wish sometimes it was always like black and white, straightforward. Now, remember, were you on the very first webinar where I talked about the cervical research?
Yes.
Do you remember I talked about they took 400 subjects. Okay, they built a mathematical model based off of what they had seen. So they built this mathematical engineering model of what they thought the spine should look like, which means a 42-degree curve and 0 millimeters of anterior head translation. Okay. Then they compared that. They took 400 x-rays of a population of patients who were getting care in a office, I believe it was Massachusetts. And what they did was they looked at those 400 people and they averaged out the stats to see what was the average curve. What did the average curve look like? And the average lordosis was 34 degrees. So not 42, right? So the population normal or population average was 34 with 15 millimeters of anterior head translation. That was the average amount of anterior head translation. So, am I happy with 15 millimeters or less? To answer your question, yes, that's what I try and go for. The shallower their pizza angle, okay, I'll say this really slowly, the smaller, the lower their pizza angle. Because remember, a normal pizza was, 75 or less, 75-ish, 73 to 75. In a case like that, I'd want to have, as close to, 15 to 0 as possible. But if the pizza angle is higher and higher, Glenn, like 80s and 90s, they're almost always going to be left with more anterior head translation because they have a stronger thoracic kyphosis driving their head forward. So part of it is also based off of the measurements of the pizza angle. In other words, that patient's morphology, that patient's genetics. So lower pizza angles, I'm going to try and get their head closer to 0 because they have shallower inlets, they have shallower spines.
Right.
I'm trying to get everybody 15 millimeters or less because that's what the data shows us is best. But if a patient ends up with, 16, 17, their neck curve looks good, they're functioning better, all of their questionnaires are getting better, am I going to keep cranking on them trying to get their head back? No, I'm happy with that. I'll try and maintain them there, right? And so the head retraction exercise, I rarely do head retraction, Glenn, because if I have you, like if you have a loss of curve, and you don't have that specific pattern we talked about in one of the previous webinars, if I just have you bring your head back, right, and you have a straight military neck, you're not putting any curve in there. Okay, so we have to be very careful with that. That's why the Pro-Lordotic is better, because it helps to retract the head while inducing curve. So I rarely have patients do head retraction. Rarely. I typically have them do Pro-Lordotics because it brings the head back while inducing cervical curve.
That makes sense.
Now I will have patients do that. Every single patient for me that gets a cervical dental roll gets that exercise. It's dental rolls and that Pro-Lordotic, whether it's in the office or at home. And just like that, like let's say generally what I do is I take an x-ray at 3 months. We do our first care plan. Then we follow them through to the end of the year. At the end of the year, if they can stay consistent, that's generally what I feel I'm getting max correction of what I'm going to see in their spine. At that point, I move them down to their maintenance home care, and that's once a week for both Pro-Lordotic and dental roll. And if they want to fill their boots and do it multiple times a week because they get the functional benefits, they're exercising, any input that they put into their spine on their own too is only going to help them stay in a better position and stay healthier. So they can continue to do it as much as they want, but that's how I proceed in my office.
Okay, just one last quick question then.
Yes.
I have, and it's probably not a quick answer, but anyways, I have a patient currently that has an unstable C4-5 segment with a kyphotic C-spine. Is the dental roll contraindicated?
When you say unstable, define instability for you, Glenn. Are we talking about, like, is it anterior listhesis? Like, you see an anterior listhesis?
No, but what we did is we took her back. We did send her back to the hospital for flexion extension x-rays to see how unstable it is, but you can feel clunking in there on palpation. There's definitely some concerns. I haven't got the confirmation back on these x-rays yet, on those specialty views.
Okay. Okay. Well, first things first, Glenn, I wish I had short answers. And I think that's part of one of my problems is I can't keep things concise. I'd probably do a better job if I could. But all that to be said, is it a contraindication? I would say it's relative, meaning potentially. And how do you know? In that case, since you can't take a stress film on the dental roll, I would try it with the patient in office. You'd want to put the peak of the dental roll, approximately C4 or 5, at the peak of the kyphosis and see how do they feel, right? Oftentimes those really kyphotic segments, those are very damaged segments, okay? Just so you know. And when the cervical spine goes into a kyphosis, you get loss of blood flow to the brain, okay? And so those patients are going to lay on the dental roll and they're going to have a massive shock to their nervous system because they're going from a really broken kyphotic position into a lordosis. So you're probably getting, if it's a 10-degree kyphosis, they're going into 10 degrees of lordosis. There's a 20-degree change at one segment. Their brain is saying like, what the heck is going on here? They got improved blood flow to their brain. And so they can get dizzy on the dental roll. That's probably the biggest contraindication for those kyphotic segments. So you just want to make sure that you're not sending them home without proper instructions and making sure that they're not getting dizzy and, vomiting or getting really nauseous on the dental roll, then saying, I'm never using this again, Dr. Lang. So those cases, I just try it in the office a couple of times before I send them home with it. But you want to make sure that you get the peak pretty close to the apex of the kyphosis, slightly below. And as long as they're not getting nauseous or they're not getting any kind of abnormal, weird symptoms tingling into their hands, by all means, send them home. They need it. And just like I had shown you in that previous case, I'll go back up a couple of slides. Like this case here, you see this is a perfect example. It's a 15-degree kyphosis at that segment, Glenn, right? She got nauseous. I tried her a few times in the office. Oh, she didn't like it. Strong symptoms at first. And, we just went nice and slow, a couple of minutes at a time. And even, the dental roll guide says 3 minutes to start. I would do 90 seconds with her. But I also added the Pro-Lordotic so she could start by exercising, creating extension in there without just laying on the dental roll like a quick shock to the spine and shock to the system. And she got to the point where she could do both consistently without any issues. Okay. So we put the peak on her right at about C5, maybe C6 at the lowest. You don't want to go too low and you don't want to go above. Okay. But try it in office. They should be able to do okay on it. It's not an absolute contraindication at all. As a matter of fact, they got to reverse that. Otherwise, those end plates are going to die. This is a very bad neck if you don't reverse that kyphosis.
Thank you. Awesome as usual.
Thank you, sir.
Hey, Pascal, I've got another question.
Please.
If you're, so when I do exercise, I haven't used the instrument that you're using, but I'm just basically having people lie prone.
Mm-hmm.
They have a fairly neutral thoracic kyphosis. They have an anterior translation.
Okay.
Loss of curve, and then they'll do like they'll retract first. I kind of cue them that their thoracic spine moves first, head follows, and then when they finish, they look up towards the ceiling.
Yeah.
So they're restoring the curve at the top, and we do 3 sets of 15 as far as home care goes, at least once a day.
Yeah.
That's kind of what I think Michael Hall from Brain DC does it that way.
Okay.
That's an effective.
Yes. Yes. Now, the thing is with that is generally you're going to create a couple of things. Okay. There's going to be what's called thoracic extension. They're going to lift their thoracic spine and lift backwards. So it's going to flatten the thoracic spine a little bit potentially because of the motion and the exercise. I do that exercise a ton with a lot of patients because it is an effective way to retract the head. And especially those patients I find I'll do that with, Yuri, is they have head translation and they're rounded in the shoulders, their whole posture or balance is leaning forward. I will give them that exercise. Absolutely. Now, again, the hard part there is you can't really take out the thoracic spine and it can flatten the thoracic spine. So, I would select that one personally according to what that patient's thoracic spine looks like. If they're a little bit more rounded and hyperkyphotic, that is a perfect exercise for them. If they're flatter in the thoracic spine, then I would move to something like the Pro-Lordotic because it'll help to round the rib cage at the same time as we put the cervical curve back in. So it would be a little bit patient dependent, but it is a great exercise and it is absolutely one of my go-to.
Okay, thank you.
You're welcome.
Dr. Greg Zoldi has his hand up. Go ahead, Dr. Greg.
Hey, Pascal.
Hey, Dr. Greg, how are you?
Great. Sounds like we're getting a lot of thoracic training here. And that last one, is that what you would refer to what Yuri was doing? That's the Titanic exercise, correct?
The one that was prone?
No, the one that Yuri was describing, the extension forward and then the head in extension.
Now, if I understood correctly, maybe I misunderstand Yuri's question. I thought Yuri said that he had him doing it face down.
Oh, face down. Sorry, I missed that part. Okay.
Yeah, if it's face down, on the if you remember the hands-on training, Greg, I would call that one. That's the one I would call like the thoracic prone thoracic extension. So they lay on their belly, right, and they try and lift their chin. They try and look up, so they're inducing curve. They're lifting their chest to stretch everything here and strengthen the rhomboids and the posterior chain. But in essence, it is very similar to exactly that, what I call the Titanic, where I would block the rib cage with like a yoga block, right? Have them squeeze the rib cage back. It does almost the same thing standing, but yes, almost identical. They block the rib cage, stand against the wall, like Dr. Greg Zolli is talking about. They lift their chin, look up to the sky. It's doing the same thing, but they could do it standing. So that one, I would say we would do more in office than having them lay prone.
My other question, maybe a long question with a long answer, is elderly populations who have difficulty laying down, getting up, people who have compression fractures. So we're talking actually about anatomy that's just changed, and people with Sherman's. So these are all people that you likely are not going to get much change, but should you do it anyway?
Yes. Yes, yes, and yes. So compression fractures. Okay, if we're talking about an elderly population that has bone density loss, we'll start there. We have to be careful because obviously you can't adjust them the same. They're a little bit more sensitive. But all the more so, what happens in those compression fracture areas, as it heals, that area actually stiffens up and becomes probably more stable and stronger than the surrounding areas because of, I guess, the scar tissue and the damage that's happening around there. So at first, while it's acute, it's sensitive, you do not want to lay them on there. But eventually, once the compression fracture, the acute swelling, that whatever they call it, the edema is healed, and their pain is down from it, I have them put the thoracic retrainer right on that fractured area if they can tolerate it. Okay, sometimes they can't, but a lot of times they can, because you actually want to induce extension there. You want to keep motion going, because the reason it compressed in the first place is because there's more pressure building up there. And so if you leave it there and we're not trying to take pressure off of it, is it likely to get worse? Are they likely to progress and become more hyperkyphotic? The answer is yes. So in those cases, if they can tolerate it, you can absolutely use a thoracic retrainer at the apex where the compression fracture has healed. Shortman's kyphosis. Shortman's kyphosis is tricky because they've had it for years. They have degenerated end plates, right? Their vertebrae are wedged forward, so they're more likely to stay in that kyphotic position. But that would be like going back to, I guess, what I answered to with Yuri earlier is I'll tell them in my report of findings saying, hey, listen, you've had this since you were 15, you're now 45. We see degeneration, you're stiff. But at the end of the day, my goal, number one, is to keep it here, because the research shows us that this is going to get worse. There is no doubt about it. Your condition is progressive. You are getting worse. My job is to stop it. If all goes well, we might even see some correction of the curve. And I don't know what that's going to be. That might be 10 degrees for you. In a perfect world, maybe we'll get 20 degrees of reduction. So, do we still do it? Yep. We have a case that we just finished working with, and we're actually going to send a letter to try and get a prescription to put them in a kyphosis brace. But he was a 73-degree Sherman's kyphosis. I mean, the guy came in like crying in pain. And we've done 3 months. We've just did his first re-x-ray, and we've got his Sherman's kyphosis down 10 degrees. He's down to 63, and this is something he's had for years. And, we're doing some in-office traction, just opening it up, and he's laying on a thoracic retrainer at home, and we've reduced it by 10 degrees. Massive change in his quality of life and his future and his overall nervous system function by doing that. So even though you see those, you still need to try and address something like a Sherman's. So that was 2 of them. Was there a third part to that question?
Well, it kind of goes part and parcel, because it's usually the elderly and they have troubles getting up and down.
Yeah. So if they have truly troubles getting up and down, at that point, I'm not going to make them get on the ground, Greg. There's no way, especially if they're 80 something and they're having a hard time at that point. And if it's a rounded kyphotic posture, those are the people that I just stand with their back up against the wall. And oftentimes just getting their head to touch the wall is enough of a challenge for them, right? So in those cases, they have hyperkyphosis. Their head is forward, and oftentimes they have strong head translation, and they might already have a lordosis, but their head is way out forward. I just have them stand up against the wall and try to retract their head. And so in cases like that, the retraction of the head will induce a normal lordosis because they typically already have some curve in there. It's not like it's a straight military neck. it's a kyphotic posture, and we got to bring their balance back. So we know in those cases, every single centimeter for every 10 mils that you can bring the head back relative to the pelvis, you're reducing their chance of death by like 100%, just because you're improving their postural balance, their muscle tone, and you're reducing their risk for falling. So those patients, my go-to exercise is I stand them up against the wall and I just have them rep it out one after another, try and get their head to touch the wall. If they can get there, then I'll progress them to something different. But oftentimes those patients are happy just doing that 10, 15 minutes a day, and you'll get wonderful results doing that.
And even the frail population, even if they can't stand for that period of time, they could even do that seated, right?
Yeah,
That would be
absolutely.
beneficial.
Absolutely. Absolutely. You got it. You could do it sitting, grab a chair with a flat back, put it up against the wall, have them try and pull the shoulders back and drive the head back if they can't do it standing. And in a perfect world, Greg, what I would do is I would have them stand as much as they can, though, because always standing exercise will trump seated exercise, always, in terms of the proprioception, right? And so if they could even do a minute standing and then they get tired and they sit down, great. So I would say, okay, do a minute standing, do 4 minutes seated, and then, mid-afternoon, do the same thing. Try and do a minute and 15 seconds standing, and then the remainder of the time seated. So if they can get some standing, they'll get better benefits for sure.
Awesome. Thanks, Pascal.
My pleasure.
Great to see you.
You as well.
Okay, I think that's it for today, Dr. Pascal.
Awesome. Well, thank you for having me, and I'll look forward to chatting with everybody in 2021.